Hello, this is Dr. Karmalkar from HCA Florida Westside Hospital presenting a sight unseen retrobulbar hemorrhage after stroke thrombolysis. Tenecteplase, or TNK, is a genetically engineered TPA variant with a longer half-life in single bolus administration, which is now, because of its ease, become increasingly used off-label for acute ischemic events. Here we're reporting a rare case of spontaneous retrobulbar hemorrhage following TNK, which is an ophthalmologic emergency, usually associated with trauma or surgery, and basically highlighting a new under-recognized thrombolytic complication of this medication. So, we had a 61-year-old man with hypertension, hyperlipidemia, prediabetes, and pacemaker history from situs bradycardia, coming with an acute right-sided hemiparetic and expressive aphasic event. His routine labs and vitals were relatively unremarkable, and a non-contrast CT, along with CTA head and neck, revealed an acute left MCA M1 occlusion. And then due to the persistent neurodeficits and disabling features of his exam, he received IVT&K at a 0.25 mics per kilo, normal weight-based dosing. Then followed by a mechanical thrombectomy, which didn't have any complications reported. He went to the ICU for close neuromonitoring. After about 3 hours or so, it was noticed by the critical care team that he started developing left eye proptosis. He started mentioning some decreased vision, relative afferent pupillary defect on his exam, and we did pupillometry, finding elevated intraocular pressures around 30. We did a repeat or stat CT head and found that there was now an acute left retrobulbar hematoma and was compressing his optic nerve. Along with that, there was an evolving left M1 infarct. So we had to emergently call our emergency physicians because of our community hospital setting. There was no ophthalmologic on call to do a bedside lateral canthotomy. About 5 cc's of blood started immediately draining, and slowly, after about an hour or so, the pressures came down, and the intraocular pressure, along with restoration of the vision. Labs and vitals remained stable during this time frame, and then we did, I think, 12-hour follow-up CT again just to confirm how everything was progressing, and the hematoma had stabilized, no expansion or further inflammation in that area, and the evolving infarct had stabilized as well, and no expansion or further conversion. Now, some of the imaging is posted here. The first image on the top is the CTA head and neck axial view, kind of showing where that left M1 occlusion is on a MIP sequence. I know it's a static image, so it's kind of hard to tell, but if we look at relative anatomy of the circle of Willis, we can follow that left M1, and it starts to fade away, and that's relatively where the M1 stroke was. Now, this next middle image is the CT head axial view, showing the evolving M1 infarct that happened at the point of stat CT when we saw his neuro exam, along with the same CT head. If you scroll further up, we found that there was some inflammation and essentially hematoma in that left orbit. And if you compare the symmetry between left and right eyes, clearly that left eye is starting to protrude further. So basically, within our literature review, we found that RBH is a rare ocular emergency, most often associated with trauma or surgery, not necessarily spontaneous bleeds. Large TNK trials, such as the Extend 1 TNK and the NOR test, from landmark trials essentially, don't really report orbital hemorrhage. So basically suggesting that these events are either extremely rare or just under-recognized. And basically what we found is that prompt recognition of this, along with lateral canthotomy, would be the essential treatment to prevent irreversible vision loss. And therefore it needs, some sort of proper vigilance regarding this type of atypical thrombolytic complication. So the point of our paper essentially was to identify that this might be a new known complication of TNK, and furthering the need for multidisciplinary management and vigilance for these type of atypical presentations. Ultimately, we want to make this a known complication and have people within critical care, neurocritical care, etc., be able to recognize these early complications and coordinate interventions to prevent things like permanent vision loss or any further comorbidities. At the bottom are our references, and I thank you for your time.